This video is demonstrating a right-sided exploratory tympanotomy in a patient with a mixed hearing loss. This is a female patient who has had a mixed hearing loss. This has been progressive for the past 3 to 4 years, and she's using hearing aids, so she's not very satisfied. And the CT scan was done. It came out to be normal in the terms of no pathology. The footplate region appeared slightly thicker, and the Rinne's on a 512 tuning fork is negative. That is a non-compromising prerequisite for any patient we take for exploratory tympanotomy. And the plan here is, in case we do find the stapes to be fixed, to proceed to a formal carbon dioxide laser stapedotomy with a titanium prosthesis. So as you see here, we are using a speculum for this surgery. You can use a self-retaining speculum. You can use a normal speculum. The speculum should be nicely fitting. That's more important. The flap elevation should be clean without causing any trauma to the flap. And as you see here, the flap is has been elevated. And now we have to just curette the posterior canal wall. One can curette, one can drill. Normally we use both because sometimes only curetting causes a lot of pressure on the thumb in my case. So I prefer to use a drill. That's much more controlled than curetting. And appropriate size and angle drills can work very well. We reduce the drill speeds here, and it's very important to take care of your tympanomeatal flap. Excessive speeds here and the use of inappropriate burr, both in terms of their variety and size, can lead to flap tears, and that's unfortunate because you'll be contaminating the middle layer and requiring a graft. So the goal here is to remove the scutum slightly in a bit to expose the entire stapedius tendon posteriorly, and superiorly to expose the inferior half of the fallopian canal on the right side stapedotomy, and the entire fallopian canal in the left side stapedotomy. That's just because basically one needs to have a higher amount of space for manipulation and instrumentation inside the middle layer surgical field. So flap elevation and exposure are fundamental steps. These steps should not be screwed up because then the outcomes can grossly go against you. So one has to take time in having the adequate exposure in this part of the surgery. And you can see now here how we're just getting a glimpse of the incus joint and the stapedius tendon, but not the complete one. So from here on, we will require slightly more drilling, both posteriorly and superiorly, to be able to expose, and that we could do even using either a drill or a curette. It's a very good idea to usually invest in good quality curettes which are sharp and sturdy, because they reduce the work of your hand and fingers. And like I said earlier, I prefer drilling any day because I usually find it much more accurate as compared to curettes. Though it's a personal choice, curettes are very uh, commonly used for this part of surgery. And now you see how what I was talking about. The scutum has been drilled appropriately to see the slightly more than inferior half of the fallopian canal, the oval window, and most of the stapedius tendon. And now, once we have assessed the fixity of the stapes uh, footplate, like so, by contracting the malleus and seeing the movement on the malleoinguinal incudal joint and not on the incudostapetal joint, not on the vestibule, then we would use either a very small circular or a right angle hook, which we'll use in this case to basically disarticulate the incudostapetal joint carefully. One must not disarticulate the incus itself. This is generally quite a favorable situation because the footplate is nice and thin. You can see that it's not an obliterative focus, which is very important. And here, once we have assessed, we'll be using the same right angled hook to gently disarticulate the incudostapetal joint. Now, the movements here have to be microfine and highly restrained and restricted to be sure that one doesn't cause any dislocation or forward pushing of the incus that could go against in terms of overall prosthesis placement by causing an oblique and a longer angle. And once this step has been done, usually we proceed to removing the stapedius tendon. We could use it normally using a curetting scissors, or in this case, we would use a carbon dioxide laser to virtually make it contact free. Here we're using a sizer to measure the distance between the top of the incus and the vestibule or the footplate region. And if that approximately is 4 millimeters, then that's good, because then we need to add just 0.25 to it for the amount of distance it goes inside the uh, vestibule, or 3.75 because we are measuring the top of the incus. From the bottom, it would be 4. So once again, now this part has been done. After the measurements are made, we will just use the laser to vaporize. As you see, the laser beam is focused on the stapedius tendon and it is vaporized. The usual settings for this part of the surgery on a carbon dioxide laser platform are 8 watts for this step, as well as curettomy, and 20 watts, 19 to 20 watts for the foot plate vestibulotomy. Once the stapedius has been cut, then we do the posterior curettomy. Once again, like so, you see that the posterior crura is being vaporized, and that leaves the stapes footplate anchored to the stapes with just crura with just the anterior crus, and mostly that is not very well visible, so can simply be fractured downwards. You use the same hook to now fracture this crura downwards after making sure that the posterior cut has been either removed completely or has been reasonably thinned, so it becomes weak and fragile. So sharp downward push onto the stapes will just fracture it, leaving the footplate intact. It does not have to be a slow, gradual pressure. It has to be a sharp flex so that it gets fractured in one go. Constant pressure can sometimes injure, causing a floating footplate. Now, once the stapes crura remnant has been removed, now we focus our attention towards the footplate region, and we create a hole in the middle or the posterior part of the footplate. As such, you see here using a 20-watt setting, and this is 0.5 millimeters because we would be using a 0.4 millimeter piston in it. As we see, most likely the hole is not complete, maybe because of lesser depth of the laser. And once that is not complete and you don't see the fluid coming out, if you have to double verify it, you do not have to make another shot, because another shot will never be at the exact same spot, and that would make a larger than usual stapedotomy, which would be counterproductive. So we use the scutum to basically just kind of gently open the slightest amount of bone that was left, and the scutum is primed at 0.5, sized at 0.5 millimeters, to be very sure that we are not over or undersizing the footplate hole dimensions. And post the hole has been surely made, we use a 4.25 titanium soft clip piston is being now placed here. We keep all sizes with us just in case we feel that a certain piston is shorter than usual. Then we can change to a longer piston. And you see here how comfortable this is. It does not require crimping. We simply position it onto the long process of incus and gently push it onto the long process to basically crimp, and that's all. This is all that is about this surgery. Easy crimping, no mechanical force on the footplate, no mechanical force on the stapes. This is pretty much contactless surgery, as soft as it can be. And now we already have a clot with us from the middle ear, which we can simply put onto the vestibular opening, larger than usual, but that's fine. These clots will get reabsorbed, and once the clot is placed in the vestibule, you simply would put the tympanomeatal flap back. And this is put in the flap back neatly, and just putting some gel foam on this flap to close this. Any large suction must be strictly avoided because that can suck on damage on the flap. So always be patient by using a thin appropriate suction. You can just put in the skin neatly back to where it belongs.